All right. So good morning. Today the topic is status epilepticus. I have made some new updates on this, partly because there are many new advancements in status epilepticus, especially in the management in the recent 2 years. So in the past, we defined status as 30 minutes. Then after that, we changed to 5 minutes in children in 1999. This was 21 years ago. But now it's no longer 30 minutes. It's no longer 5 minutes in children, but also in adult. We define a status as after 5 minutes of tonic-clonic seizure here. But if it's focal seizure, if impaired awareness, which is less severe, then we can take 10 minutes. Otherwise, in absence status, we can use 10 to 15 minutes because sometimes they will recover themselves. However, if we fail the first and second line of treatment, we call this refractory status epilepticus. If after a day, we call them super refractory status epilepticus. But there is a new definition as well, which is acute repetitive seizures. Acute repetitive seizures is defined as 3 or more seizures within 24 hours, and some of them has poor prognosis as similar to status epilepticus. And because of that, in certain situations, we would want to treat them as status as well. I will define and explain this more afterwards on acute repetitive seizures. Just remember, 10% of your patients will have status epilepticus. In fact, they present with status, and therefore be careful. Some of the status epilepticus will subsequently progress to epilepsy in the future. So this is the classifications of status. We use a similar ILAE seizure types classifications. As you can see, we can divide them into either convulsive or non-convulsive. And afterwards, we divide them into generalized focal or in the convulsive group, or generalized or focal in the non-convulsive group. Under the focal status epilepticus, which is called epilepsy partialis continua in the past, we can divide them briefly into impaired awareness or aware seizures as used in ILAE classifications. This will be useful later on to classify and to define the severity as well as to identify the underlying etiology. There are other mimics of status. Sometimes people with psychogenic seizure, they develop status epilepticus. I always use this example whereby patients presented with continuous seizures in the emergency, and she was intubated 3 times in total over 3 years, which means 1 intubation a year, partly because she looks like status epilepticus, but the cause is psychogenic. Sometimes people with uremic encephalopathy, they have myoclonus. Some people with hypoxia, some people with severe encephalopathy with EEG abnormalities, but they are not having status epilepticus, and we need to be careful. Especially metabolic encephalopathy, they have triphasic waves. They look periodic, but doesn't mean that these periodic waves are epileptic or epileptiform. And that's why the treatment is not anti-epileptic drugs in metabolic encephalopathy. So give you some examples of what is focal aware seizures, including twitching of the thumb. Let's say if you look at the video now, and my video, then patient have intermittent rhythmic twitching of the thumb because of a stroke or because of a tumor, but he is aware. This is called focal aware status epilepticus. Sometimes the patients become unaware, and a patient develops psychosis, patient develop continuous aura, patient develop automatism. Then we'll call them focal impaired awareness status epilepticus. But sometimes some of the focal seizure or focal status epilepticus has no clinical correlations. They are non-convulsive, and in this group, we group them under non-convulsive focal impaired awareness, status epilepticus. Epson status is not common in our lab. We have one patient, 14 years old boy, still studying, but he will have 3 hertz spike and wave every few minutes or few seconds. So a run of spike and wave stop, spike and wave stop, spike and wave stop, and he doesn't aware of that. He has no symptom. He can still do mathematics. He can still answer questions during the episodes. But the EEG show very frequent bursts of 3 hertz spike and wave. This is called Epson status epilepticus. Mild chronic status, we don't see them that often in juvenile mild chronic epilepsy because most of our patients, they will rather have generalized tonic-clonic seizures. But in hypoxia, in metabolic encephalopathy, like especially uremic encephalopathy, patient will have continuous jerks or myoclonic jerks. In the past, we call them myoclonic status epilepticus. But the myoclonic usually responds only to GABAergic drugs. They don't respond to any other anti-epileptic drugs. Psychogenic status epilepticus, as I mentioned, if a psychogenic seizure is prolonged more than 5 minutes or 30 minutes, then they have psychogenic seizure status. But when we do EEG for them, their EEG will look normal. All right. So I'll open chat. Everyone can open your chat now. So I'll give you a few cases and you let me know which type of status do you think it is. Huh? So 47 years old man presented with a generalized tonic-clonic seizures but did not regain his consciousness after the seizure. Do you want to perform an EEG? Yes or no? Okay, huh? So patient have generalized tonic-clonic seizure during emergency. There's no time for EEG. But after that, and patient didn't regain consciousness, you want to ask whether this is still a continuous status. You can consider whether you want to do EEG straight away. Because the only solution to the answer whether this is status or not, when there's no more convulsion, is EEG. Without EEG, we will not be able to tell whether patient is post-ictal drowsiness or because of underlying etiology like encephalitis, or they are unconscious because of continuous status. So in the EEG, in this EEG example, you see continuous activity over the occipital region at the right side during this unconscious period, and therefore we call them non-convulsive status. So which one do you think it is? Which type of status in these patients? Is it convulsive or non-convulsive? Is it convulsive or non-convulsive? Is it C or NC?
NC.
NC. Okay, someone straight away said this is focal, right? Correct. So this is non-convulsive. And this is focal. Partly because non-convulsive because patient has no more convulsion, is only have impaired consciousness. But patient is focal because the EEG only show continuous activity on the right occipital lobe. So it's a focal non-convulsive status epilepticus. Second case, 72 years old lady with right MCA stroke 2 years ago. Now have lower limb jerks without impaired consciousness. This is straightforward. So EEG show a periodic sharp on the right side, the same side as a stroke. Okay, so what is your diagnosis? How would you treat? Let's come back. This is the EEG. If you look at the EEG as CZ as well as the EMG here, you will see a jerk in the EMG and you see a CZ sharp waves accompany the jerks. So the CH sharp wave is periodic, but they are accompanying a jerks. So which one would you call this? Is it convulsive or non-convulsive? Definitely it's convulsive or patient have jerks. But which one it is? Which type of status epilepticus is this? Is it focal or generalized? Is it impaired awareness? Okay. Focal convulsive, aware or impaired awareness? Aware. Yeah. In the old days, we call this simple partial status epilepticus or epilepsia partialis continua. All right. But yet now there is a new term we can always use, focal aware status epilepticus, which is a new term following the ILAE classifications. The third case, 14 years old boy with generalized tonic-clonic seizure a month ago. Now with a brief generalized tonic-clonic seizure only, there's no history of absent and myoclonic jerks. But what happened is the EEG showed this very frequent spike wave, and it's both sides. It's on the right side as well. The internet connection is not clear. Sorry, just now the connection is disconnected. So let's do this. So this is the third case. So what happened in this patient is that you can see spike and wave on the right side as well as on the left side. So, and then it's continuous, it's 3 hertz, 1, 2, 3 in 1 second. So which one do you call this? Patient has no more jerks, no more generalized tonic-clonic seizure, it's only before the EEG. So is it convulsive or non-convulsive? Generalized non-convulsive. Okay, how about others? Is it generalized or focal? Yes, non-convulsive. Is it generalized or focal? All right. Okay. So what happened is the patient doesn't have jerks anymore. The GTC is before the EEG, but the EEG show continuous generalized discharges. So this is non-convulsive, but they are generalized. And in this patient, the patient has 3 hertz spike and wave, 14 years old, as I mentioned. So he has absent status epilepticus. This is one of the examples of absent status that we have met over many years. What are the commonest causes of status epilepticus? In fact, is drug withdrawal. Drug withdrawal is one of the commonest cause, partly because many epilepsy patients, as I said, 15% of them have status because they miss their dose or when they are not taking medications. However, there are other causes. For us, we just divide broadly into structural and metabolic. So what is the difference between acute and remote? Acute means the injury occurred within the past 2 weeks to 2 to 4 weeks, which is very recent. Or sometimes it occurred just a day before. Remote means the injury occurred at least 1 month or more. It may be head injury or accident 3 years ago and now have a seizure. And we call this remote symptomatic or remote structural injury. The drugs I have covered in the previous lecture, partly because there are many drugs that we need to be careful. For pain, we talk about tramadol. For antipsychotic, we talk about clozapine. For anesthetic agent, we talk about propofol. For antibiotics, we talk about imipenem and cefepime. How long did the seizure need to occur before it caused permanent brain damage? Most people say 30 minutes. But for us to see brain changes, we need at least 60 minutes of seizure. So for this reason, there are two criteria. The first one is we want to control the seizure within 30 minutes. Second, if 30 minutes cannot, we at least want to control them within 60 minutes. So 30 minutes is phase 1, which include first and second line of anti-epileptic drugs. 60 minutes is on anesthetic agent, and after 1 day, we call them super refractory epilepsy. 1 hour is a good cutoff point. If you see, if the patient's seizure or status is less than 1 hour, the mortality rate is only 3%. But if the status persists more than 1 hour, mortality rate go up to 30%. And therefore, important rules is we want to control the status as early as possible, irrespective of the underlying cause. This is something interesting in predictive outcome. How can we predict the outcome or mortality of status epilepticus? In 2008, there is a score called STESS score. ST is status, E is epilepticus, severity, S is severity, and S is score. So the STESS score consists of 4 components. One is consciousness, seizure types, age, and previous history. And just want to clarify or notify you. Look at this. Non-convulsive status in coma is in fact worse than a simple partial status or generalized convulsive status. So coma is important. Non-convulsive status is another additional predictive factors. Second point is this: anyone without history or previous history, meaning that they are not epileptic patients or people with epilepsy, then the chance of them having mortality is higher than those with previous history of epilepsy. As I told you, most epilepsy patients develop status is because they miss their dose. But for those with no reasons, they may be because of acute problem like stroke, infections, paraneoplastic, autoimmune, and so on. So we need to be careful about that. The next score is called EMSE score. EMSE score is proposed in 2014. It is much complex, but apparently if you have the chart, then you can chart it within 1 minute. It is looking at a few things. The first is etiology, comorbidity, age, and EEG. Let me clarify a little bit on EEG. If you look at this, burst suppression score 60 points. ASID, which is continuous interictal discharges, or after status interictal discharges, score 40 points. And these are periodic discharges, either lateralized or generalized. No matter which one, they will call 40 points as well. And any points more than 64 indicate a higher mortality rate. So these are the two predictive chart that we can use. We can use a simpler one called STESS, or use a more complex one called EMSE. These are used to predict the mortality of status epilepticus. So for investigation, initially I want to talk a little bit more on EEG, but Prof Tan has his lecture on EEG in status epilepticus and intensive care. So I'm not going to touch on this, how do we classify or diagnose epileptic status epilepticus based on EEG. In terms of investigations, last time I used to talk about SPECT scan. SPECT scan is useful and available in many hospitals. We use this for oncology. In status epilepticus, especially, we have no clear etiology and don't know where is the origin. We can use SPECT scan. Hyperperfusion in the SPECT will be consistent with status epilepticus. But recently, there are papers starting to talk about CT perfusion. CT perfusion is used especially in patients with stroke. A patient with stroke and hemiparesis come in and become unconscious. You're not sure whether this is status or not, or it is purely because of severe stroke. One of the tests you can do is CT perfusion. In stroke, you will have hypoperfusion. However, in seizure or status epilepticus, you will have hyperperfusions of that region. So management, I will include some of the updates in the management and just beware of the changes compared to the past. This is guideline, nice guideline in 2004, which is very old, already 16 years ago. You can see that the first line is using lorazepam. Second line using phenytoin or phenytoin. They also propose using phenobarb bolus. And third line is using propofol, mida, thiophantom, or anesthetic agents. So this is the first, second, and third line of treatment. And remember, first and second line we need to give, or we want to give within 30 minutes or 1 hour as soon as possible. But this is the American Epilepsy Society guideline, AES guideline, which has update and show some new changes. The first changes is pre-hospital therapy. You can see here, if someone is having seizure at home or in the ambulance, these are some of the options we can use. The first option is IM midazolam, and therefore in the ambulance, it's important to have at least 1 or 2 vials of midazolam, 10 milligram. And if patient develops status, we can straight away give IM midazolam. Second one we use a lot in Malaysia is buccal midazolam. We are no longer using that often rectal diazepam. So buccal midazolam is easy to use. They keep a bottle at home in the fridge. When someone develops status, especially in children or in patients with very frequent seizure, then we can give a 10 milligram of midazolam in the buccal region. So you just put a syringe, withdraw 10 ml, it's just 1 ml, go into the buccal and then inject slowly without a needle. This will be absorbed through the buccal mucosa. For country without buccal or IM midazolam in the ambulance, another option which is cheaper is IV phenobarb. IV phenobarb of single dose doesn't need intubation to give IV phenobarb. Second one is rectal diazepam, but it's inconvenience for adult, especially for female or even for male. So why are we talking about lorazepam while most of the country are only giving diazepam? Diazepam in fact is very much cheaper and is much easily available. IV lorazepam is not marketed in Malaysia and we have no IV lorazepam. But IV lorazepam has a few advantages. The first one is it is very stable. As you can see, there's no active metabolites. Very stable drugs, lorazepam. Secondly, we have tablet lorazepam, but we don't have IV. Secondly, lorazepam duration of actions lasts from 12 to 24 hours. Just imagine if you give diazepam, patient seizure stop. After 30 minutes, patient seizure occur again. Perhaps because the action of diazepam is over. Whereas for lorazepam, the action of duration lasts up to 12 hours to 24 hours. So it will give longer protections to the patients using lorazepam. But now we have another alternative, which is IM midazolam. This is a rampant trial, but remember, midazolam duration of action is also very short as 15 to 30 minutes. So it's like diazepam, we need to give or consider repeated dose or maintenance with phenytoin after the seizure is controlled with midazolam. So in this rampant trial for pre-hospital admissions, they realized that midazolam is actually as good as lorazepam because it's easier to give. It doesn't need IV line, doesn't need to set a granular, although it takes longer to achieve a bioavailability, but yet it's easier to give, and therefore the effect is as good as IV lorazepam in the ambulance or in the pre-hospital state, or even when the patient arrives in the casualty. When you have no time to set granular, you can straight away give one dose of IM midazolam intramuscularly. This is important, and remember, useful for acute status initial treatment. After that, for second line in AES, you realize that it's no longer phenytoin. It's stated here phenytoin, and I'll tell you why. And it also includes two other options, which is valproate acid and levetiracetam in the second line. So these are no longer third line. Valproate and Keppra or valproate and levetiracetam are second line in AES guideline. Phenytoin, valproate, and levetiracetam. So this is a 2011 comparison trial. And after that, they have a repeated trial again later on. And this one used STESS score for seizure or severity predictions. One of the interesting things to see here is that epilim or valproate acid seems to be better than levetiracetam. So in valproate acid, failure rate is 25, which means 75 success rate. Phenytoin is 41%, which means success in 60%, and levetiracetam is 48, which means success in 52%. So epilim or valproate acid seems to be better. And remember, if you see what are the predictors or good predictors for mortality, those are either the etiology or the STESS score. And look at what are the deadly etiology here, which was used subsequently in EMSE score as well. The cause of the etiology includes stroke, tumor infections, autoimmune, AIDS, and metabolic disturbance leading to coma or sepsis. So in 2019, there is a repeat comparison again. This time they are using a standard dose-to-dose protocol. I want to highlight the dose first. Levetiracetam. Can you tell me what is the dose you use for status epilepticus in levetiracetam? What is the dose of levetiracetam you use for status epilepticus?
50 milligram per kg.
50.
50.
So if someone is 60 kilogram and you use 50 milligram per kilo, will be 3,000 bolus dose. All right. So in Indonesia, if you don't have IV levetiracetam, you can use oral because the gut absorption is as good or almost similar to IV. So you can crush the levetiracetam, put in the NG tube as a treatment for levetiracetam. All right. How about valproate? What is the dose for valproate that you use?
We don't have IV vapor.
Oh, okay. But in the initial day, when people use valproate, they use 10 milligram per kg as a bolus, which is very little. 10 milligram per kg for 60 kg is 600 milligram. Sorry, it's 600, correct. So what happened nowadays is that the dose they have proposed and considered to be safe for levetiracetam is 60 milligram per kg. So we can use as high as 4,500 milligram in a very big size adult as a treatment of status epilepticus. For sodium valproate, we can use up to 3,000 milligram as bolus, and this bolus no longer requires low bolus. We can all give in a fast bolus up to 10 minutes. So all of this regime were given within 10 minutes and their outcome is about the same. This is a success rate in all the three, and you can see that the area under the curve overlap between all the three treatments. And therefore nowadays, for second line, it's no longer Phenytoin. We are using levetiracetam and valproate as well as a second line. And remember, high dose and give quick. Higher dose and faster rate in valproate. As you can see here, in the old days when we start using valproate, is in fact we are using only 10 milligram per kg. After that, we increased to 30 milligram in elderly, which is safe in pediatrics, 30 milligram. And now the recommended dose is 40 milligram per kg, valproate over 10 minutes. So this is the changes in doses of our sodium valproate for status over the year. For levetiracetam is also the same. In the past, we are not sure how much dose and how quick to give. So some people suggest 15 minutes, some people suggest 30 minutes. But now we are using up to 4,500 milligram over 10 minutes. And for those countries without IV, you can use crush oral tablet levetiracetam and give through NG tube if the patient have NG tube. Now let me cover about Phenytoin, Phenytoin. Phenytoin is much better, but it is very expensive compared to Phenytoin. So therefore, many countries doesn't have Phenytoin. We are still using Phenytoin. And remember, Phenytoin infusion rate is 50 milligram per minute. In the old days when I started housemanship, we'll just mix the Phenytoin of 750 and then we give infusion rate over 1 hour. Very, very slow and it's not as effective. So after that, we realized we should give 50 milligram per minute. So even for 1 gram of Phenytoin, it takes about 20 minutes to finish the infusion. And we need ECG monitoring while giving Phenytoin. So it's very difficult to give fast bolus when you use Phenytoin, but it is very much cheaper. And therefore now we are still using Phenytoin. Okay, so remember cardiac arrhythmias risk for Phenytoin and Phenytoin is the same. Phenytoin is 25, Phenytoin is also 25%, and therefore we need ECG monitoring. So if we only have Phenytoin in our hospital, how can we give Phenytoin fast? This is one of the important questions that we have always asked. So one of the good paper, which is a conceptual paper that I have quoted many times is this. The paper say we don't use first line and second line terminology anymore. We don't say diazepam is first line, Phenytoin is second line. This paper said we give them together. First and second line, give together. So what it means is that when a patient comes in with status epilepticus, you give diazepam and at the same time quickly prepare phenytoin and give phenytoin at the same time. As I said just now, phenytoin takes about 20 to 30 minutes to complete the infusions. So what it means is that by 30 minutes, you will have already completed your first and second line, even though you are using phenytoin. And if patients control, then it's good. If patient's seizure is not controlled, then you will need to refer for anesthetic agent and intubations. So this is one of the important and useful paper that I found critical and applicable to our Asian country. Why the first and second line doesn't work? Sometimes it doesn't work because the patient has psychogenic seizure, or the treatment is delayed. The patient's status is already half an hour at home, and when they come, it's already late. Or the dose we use is too little. We may be just using 1,000 milligram of levetiracetam. The dose is small. In the old days, even for phenytoin, we may use a much lower dose like 500, which is actually just 10 milligram per kg, rather than 20 milligram or 15 milligram per kg of phenytoin. And the third point is we will fail to identify and treat the underlying etiology, which cause persistent seizure. So coming to treatment of refractory seizure, these are some of the points that I want to cover, especially on phenobut and ketamine. Why I use phenobut more than thiopentons? Thiopentons is a pro-drug. It has less active metabolites later on. But in our experience is that when we use thiopenton, many patients develop seizure within 24 hours. So the bolus of thiopenton works, but the maintenance of thiopenton doesn't work. And therefore, patient develop status subsequently, or the patient cannot tolerate the higher dose of maintenance in thiopentons. Whereas when you give phenobarbital, the duration of action is longer. It will redistribute to the fat and come back later. And what happens is that after the initial dose, sometimes we need up to 1,000 or 1,400 milligram. We give 600 first, then 200, 200, 200 until we achieve burst suppressions. The burst suppression is still seen even when we repeat the EEG the next day. What it means is phenobut actions continue or maintain for at least 1 to 2 days and is more sustained in controlling the status epilepticus in our experience. So this is burst suppression. You can see the EEG have a burst here with a suppression after we have given 1,200 milligram phenobut. And for definition of efficacy, we need a burst suppression at least 5 seconds. For here, 1, 2, 3, 4, 5, 6, 7. So at least 5 seconds of burst suppressions need to be achieved to have a sustained effect after 24 hours. Burst suppressions can increase mortality and can cause hypotension, but it's more effective in status, and therefore we will consider those with very refractory status epilepticus. Okay, so sometimes I use EEG when I give phenobut to monitor or to determine whether I have achieved burst suppressions or not. So is burst suppressions necessary? In the hospital with continuous EEG monitoring, which means you can apply the EEG 24 hours in ICU. Then you can continuously adjust your dose of thiopenton or propofol accordingly. But if we only can do EEG once or twice a day for a patient, then we may need to have a confidence of sustained effect for more than 24 hours. Then burst suppression is useful, and that's why it's still used in my hospital. Just to let you know that burst suppression will have mortality, but mortality in refractory status epilepticus is actually very high and is in fact independent of the extent of birth suppressions. So with or without birth suppressions, the mortality is about the same. So how long do we want to maintain therapeutic coma with anesthetic agent in the refractory status? In the old days, we talk about 48 hours. Now, we talk about 24 hours. If we can achieve anesthetic agent and seizure control with higher dose but shorter duration, we may have a better outcome at the end of the day. So what we want to do is we want to make sure we use adequate high dose but shorter durations. Like phenobarb, I only use a bolus, maintain 24 hours burst suppressions, and then I will start cutting down the phenobarb dose after that, or even thiopenton or midazolam. We doesn't want to maintain for too long. So the ideal is 24 hours now, and see whether patients can be withdrawn or can be reduced their anesthetic agent. This will improve their outcome. Now I talk about some other alternatives quickly on a few options. But before we go to that, what is the explanation of refractory status epilepticus? One of the explanation is this: individualizations or internalizations of GABA receptor. So what happened after prolonged status? The GABA receptor, as you see here, will slowly be eaten up and pushed into the cells. They are no longer effective. So all the GABAergic drugs like sodium valproate, midazolam, benzodiazepine, phenobarbital, they are no longer effective in treating the refractory status epilepticus, and we need to consider other options. And these other options are looking at glutamate. So ketamine is on glutamate, perampanel is on glutamate, whereas lycosamide is on other types of sodium channels, which is a slow sodium channel, and topiramate is also has a lot of actions on glutamate receptor. So lycosamide is no longer available in Malaysia because of no UCB distributor. But lycosamide was very useful when we first using it. Firstly, the dose of lycosamide is straightforward, is 200 to 400 milligram bolus. It can be given very quickly, over 3 to 5 minutes, and the success rate is about 50 to 60%, as similar as to levetiracetam or valproic acid. But we are no longer having the choice of lycosamide in Malaysia. Okay, so this is the second systematic review done in 2017, and the number is 522. So the outcome is good. Ketamine is another option I use often now for super refractory epilepsy or status epilepticus, mainly because ketamine is a glutamate antagonist, which is the NMDA receptor antagonist. So it is not working at GABAergic receptor, and therefore it is a good choice, and we can use the dose as low as 0.9 milligram per kg per hour. But nowadays, some people push the dose as high as 10 milligram per kg per hour with a good outcome in super refractory status epilepticus. 60% here is not only in status, but is super refractory status or in refractory status, using as a third line or fourth line. So ketamine is one of the good choice that you can consider when the initial treatment failed. Remember, the dose I use here in Malaysia is 1 to 3 milligram per kg, depends on how refractory is the seizure is. We also start to use a lot of perampanel, because the perampanel tablet can be crushed and be given through the NG tube. Usually I use 8 milligram of perampanel, but the dose of 32 milligram can be given. The normal maximum daily oral dose we use in clinical practice is 12 milligram, but in status epilepticus, it can go up to 32 milligram. And we can see that although this is a small cohort, the response rate go from 17 to 100%, partly because these are mainly case report or case series. We still need a good randomized trial to determine the efficacy of oral perampanel in status epilepticus. So if you have sample or if you have perampanel in your hospital, you can go up to 8 milligram. If it's still not working, you can add another 4 or 8 milligram to go to 16 milligram. These are the regime I use. I crush all the 8 milligram, put in NG tube and see whether it responds. And we should see the response within 1 hour. Topiramate, I also use topiramate oral. We crush as well, give through NG tubes. And the dose I use is 400 milligram of topiramate. And then maintain with 100 milligram per day. This is used in one of the prospective study. Similarly, 400 STAT and 200 BD, but our maintenance is smaller. Some of the retrospective studies start with 100 milligram and titrate to 400 gradually, depends on response. But we can see that the response rate is only 25%. And remember, these are refractory or super refractory status. Zonisamide is something new that we also try to use. Zonisamide is cheaper than topiramate. Although it proposed using a 100 milligram initially, but we can go all the way to 400 milligram crush in and give through NG tube. The success rate is not as high, it's only 16%, but remember this is just a start and the number is small. For other choice, the next one I'm going to talk about is steroid. Steroid is useful, especially you think the cause is autoimmune. Sometimes we don't have autoimmune screen or autoimmune screening is negative or there is no MRI or other changes that to suggest autoimmune. But yet, seronegative autoimmune encephalitis is responsive to steroid in some case report that we have seen. So as I said, if it's autoimmune limbic encephalitis, Hashimoto, paraneoplastic, cerebral lupus, then the treatment is not anti-epileptic drugs, but to give steroid to control the status epilepticus as well as to treat the underlying etiology. So this one is on seronegative. You look at the lower one, is on seronegative autoimmune encephalitis. Even if the autoimmune screen is negative, steroid may be still useful and should consider if there's no contraindications. The last one is on a hormonal neuro agent or called neurosteroids. This is one of the example called allopregnanolone. One of the important thing is it works at the GABAergic receptor. But as I said, GABAergic receptor will be invigorated, they'll go inside. So how does it work? This hormone or these steroids work as the external or extra-synaptic GABA receptor. If you look at the picture, these are the GABAergic receptor outside the synapse. And therefore, they are still there even after a long time of status epilepticus. Now, we started to have case report, but we doesn't have trial yet to confirm the use of allopregnanolone, but this is something good or useful in the future in refractory or super refractory status epilepticus. So in conclusion, I've informed you a few key principles. The first one, if you have pre-hospital treatment, give them either in the ambulance or at the door of emergency. And the one that I recommend is IM midazolam. Second, use phenytoin and benzodiazepine together. Give them, while you are giving diazepam, prepare your phenytoin dilution and start the infusion of phenytoin together or after your diazepam. so that they can both be given within 30 minutes. The second point I also mentioned is don't always depend on phenytoin. There are other options including levetiracetam and sodium valproate. Especially if you don't have IV, you use oral levetiracetam, crush them, and you can try that. Other things that I have tried is perampanel and topiramate. I don't use carbamazepine oral anymore because I'm worried about Steven Johnson in a high dose, after using high dose carbamazepine. Then the next one is in a desperate situation, remember ketamine. Ketamine work at glutamate receptor. If not ketamine, then you think about immunotherapy if someone etiology is slightly autoimmune. Okay, thank you very much. Do you have any questions?
Prof, I have a question.
Yes.
For after the second line anticonvulsant fail, which one is the most preferred drug you use according to your experience? You prefer ketamine or thiopental, or do you also use propofol?
When we send to our ICU, our NS will use thiopentons. But what happens is if the thiopenton cannot control the seizure, then we will do EEG monitoring and try phenobarbital. But prior to that, there are some other options, especially weekend and we have no EEG service. Then we use alternative like midazolam, propofol. So
Yes.
thiopenton, mida, and propofol if no EEG. If we have EEG, then we try phenobarbital.
Oh, yes. And how about the time frame? Do you follow the time frame for American guideline, like 5 to 20 minutes, 20 to 40 minutes? Or because previously we follow, our previous guideline was like we give, after 5 minutes, we give IV diazepam or IM midazolam, and we wait for 5 minutes. And then if the seizures continue, we use a second line like phenobab or Phenytoin. We wait for another 20 minutes, and after that, we use the third line drugs. Now, current guideline is not like that 5 minutes, 10 minutes, 20 minutes. Current guideline follows the 5 to 20 minutes, 20 to 40 minutes, like that. So in Malaysia, which time frame do you follow?
The problem of the time following the time is the preparations. A lot of times we take some time to break the valve, to withdraw the drugs,
Yes.
and to give them. So in order to make sure everything is fast, there is already some changes. In the past, when we give diazepam, in the old guideline is 5 milligram, 5 milligram, 5 milligram, 5 milligram, total of 20, but give in 4 time frame. Nowadays, we give straight 10 milligram and wait for 5 to 10 minutes and give another 10 milligram of diazepam, 2 doses of diazepam. 5 minutes is not enough to see the response for midazolam and diazepam. Sometimes it takes longer to enter the brain. So I usually encourage them, and what we are trying to do now is while they are giving diazepam, they start preparing phenytoin so that the infusion can go in whenever it's ready. So at the end, we will want to achieve the 30 minutes timeline for first and second line if we can. Otherwise, at least within 40 minutes, we want to give first and second line.
Okay. Thank you, Prof.
So there's another question here on the chat. What would you do if the patient come to emergency ward with convulsive status after 1 hour or more? Which drug should we give? We should treat them as new, fresh convulsive patients. Use benzodiazepine first. We will still use first line, followed by second line, although they have already having status for 1 hour at home.
Prof, are you going to give another lecture for acute repetitive seizure?
Oh, sorry, I have mentioned the STESS. I'm supposed to mention that one of the STESS score is used in acute repetitive seizure. I thought I have included the slides here. So what happened in that study is that they realized acute repetitive seizure with high STESS score, we should treat them as status. So what score to use is more than 3. Okay, so I repeat the sentence. Someone have seizure 3 times within more than 3 times within 24 hours with a high STESS, which is a status epilepticus severity score, more than 3, we should treat as status epilepticus.
Yes, Prof. In pediatric, test is for adults because the age is 60 years. And in
Correct.
pediatric, there is only one study using the modified version of test, which is STEPSS. So the only change is the age, which they use 2 years as a cutoff age. So in STEP score, we found that the conscious level, what is the time you assess for the conscious level? Is it during the seizure or is it during immediately after the seizure?
This is based on initial assessment. During
yes, I mean during the seizure.
During the status, yes.
Oh, okay. Thank you.
Okay, so is there any other question? If not, thank you very much. If you have video, you just on your video and let me see your face and say hi. Then I will leave.
Okay, Prof.
Okay. Well, some on or
Thank you.
All right. See you then. Goodbye.
Bye-bye. Bye-bye.
Bye. Thank you, Prof.
Bye.